Thank you all for being here. I'm Dr. Zhang from Hong Kong University Zhenying Hospital. Today I will be talking about exploring position treatment of specific psoriasis subtypes based on pathogenic mechanisms. Plaque psoriasis is the most common form of disease, and the indications of newly approved biologics and small molecular therapies likewise focus on plaque psoriasis. By contrast, the treatment options for rare special type psoriatic variants lack high-level RCT evidence and guideline recommendations. We therefore asked whether precision drug selection for these uncommon subtypes could be guided by differences in their pathogenic mechanism. To explore this, we conducted some preliminary experimental and clinical studies on EP, GPP, PPP, gouty psoriasis, and here present our findings. First, we assessed the efficacy and safety of IL-17 inhibitors in patients with EP. As you know, EP is perhaps the most alarming form of psoriasis, truly a life-threatening variant. It is causes a pronounced type 2 immune activation, which manifests clinically as intense, intractable itching, and dramatically elevated serum IgE levels. Clinically, we can divide EP into two categories, stable one and unstable one. Unstable EP is far more precarious. Patient exhibit diffuse erythema with mild to moderate scaling accompanied by marked edema. This form carries a high risk of acute systemic crisis, including secondary infections, severe hemodynamic disturbances such as generalized edema, high output heart failure, and even shock and major adverse cardiovascular events. Because of this dangerous and stable EP demands our most urgent and aggressive intervention, proper recognition and targeted therapy are essential to prevent both morbidity and mortality in this vulnerable patient population. Our previous studies have confirmed the type 2 inflammation signature in EP demonstrated by Staphylococcus aureus colonization, reduced AMP, and elevated IL-4 and 13 levels. Single-cell sequencing of EP patient samples and studies in an EP animal model revealed that vascular endothelial cell subtype PCV is highly activated and proliferative, accompanied by significant activation of IL-17 signaling pathway. This may also explain the pronounced edema and capillary leak syndrome observed in EP. Since IL-17 is a key mediator of endothelial activation, we plan to target IL-17 to determine whether early intervention can reverse these hemodynamic abnormalities. We constructed a retrospective cohort with two arms, a conventional therapy group and an IL-17 inhibitor group, whose baseline characteristics were comparable. Compared with the conventional group, IL-17 inhibitors significantly improved edema, HNRS, PGA, and DLQI-EP by week 4, suggesting they may be a good choice for patients with rapidly progressive EP. By week 12, IL-17 inhibitors continue to ameliorate EP symptoms without serious AE. However, the PASI 75 response was much lower than in PV, possibly reflecting the EP's more complex pathogenesis, maybe involving the Th1, Th2, and Th17 inflammation. Now let us move on the next part, the efficacy and safety of IL-17 inhibitors in patients with GPP. In our study, we performed RNA sequencing on skin lesions from patients with GPP and PV. Compared with PV, genes upregulated in GPP were significantly enriched in the IL-17 signaling pathway and linked to the neutrophil infiltration. Skin IL-17A levels were markedly higher in GPP than in PV patients, whereas there were no differences in skin IL-36 alpha gamma RA or in serum IL-17A IL-36 alpha gamma between the two groups. Furthermore, double IF staining for MPOCD3 and L70A confirmed that most L70A in GPP lesions originated from the neutrophils rather than T cells. This finding underscored the critical role of the neutrophil-derived L70A in GPP pathogenesis, regardless of L36 RNA mutation status, and suggested that targeting this source of L70A may offer a promising therapeutic strategy. Here we present a series of acute GPP patients representing various subtypes, including the pediatric and the pregnant patients. All patients received the secukinumab and were followed for at least 6 months in our hospital. In our study, patients with Wang-Batch type GPP exhibited a rapid and sustained response to secukinumab, and those with 36 RNA mutations show significant improvement by week 2, with an especially pronounced effect in pediatric GPP cases. Next, let's move on to the next section of precision track selection for annular GPP based on genetic testing. We will share the treatment process of 4 cases with refractory AGPP patients. The first one is a 30-year-old female patient. During her pregnancy, she developed multiple annular erythema on the face, trunk, and limbs with sterile micropustules. Rash occurred intermittently. Since then, genetic tests revealed K14 mutation. As treating cyclosporin A and methotrexate alone or in combination failed to achieve the adequate control. Treatment with ixekizumab attained a PGA score of 1, maintained for at least 4 years. The second one is a 30-year-old male patient. He has a 20-year psoriasis history. Pustules appeared for 1 month. WES sequencing revealed no abnormal mutations. After 4 weeks of L17 inhibitor therapy, poorly controlled and pustules reoccurred, switching to ustekinumab, resulting in a PGA score of 1 after 4 weeks. One secondary failure occurred after 1 year of treatment with ustekinumab. The combination of apremilast and ustekinumab enabled the patients to achieve a score of 0 on the PGA. The next patient is a 34-year-old female with 10-year recurrent scaly erythema and pustules over the entire body. Initial onset appeared during the first pregnancy, and the rash occurred on the second pregnancy and persisted thereafter. Genetic tests identified L36 RNA mutation. Regular L17 inhibitor therapy achieved PGA 0 to 1, and the response waned after 8 months. One switch to L1223 inhibitor, the patient got transient improvement but lost response after 6 months. And addition of a PDE4 inhibitor was ineffective. Relapse occurred with intensive annular erythema, scattered pustules, and discrimination on erythema basis. Administration of L36 inhibitor 900 mg resulting in rash resolution and sustained remission for a long time. And the last patient is a 23-year-old female patient with 30-year recurrent annular erythema and pustules on face, neck, and trunk, subungual pustules under the little fingernail, and Zhang fever. Previous treatment with azacitidine and cyclosporin have been effective. Genetic test revealed the L36 RNA mutation. Rash partially subsided while the subungual pustules worsened after 3 months of L17 inhibitor treatment. Regular humoral therapy achieved a PGA of 0 or 1. Rash occurred 1 year later. After 4 weeks of ustekinumab, the rash progressively worsened, accompanied by fever, joint pain, and swelling, and tenderness of the wrist and ankle joints. So splicimab 900 mg was administered, the pustules disappeared, fever and drum pain were markedly elevated, but annular erythema persist. So we reviewed the clinical characteristic of APP patients compared with the one batch variety APP cases, exhibit milder symptoms, periodic recurrences, and protracted disease course with considerable heterogeneity in genetic background and treatment responses. Our cases revealed that the patient with CAF14 mutation seems to have a good response to IL-17 inhibitor, and the patient with IL-36 RNA mutation has a good response to specific. Now let's come to the first section, efficacy and the safety of IL-12/23 inhibitors in refractory gutted psoriasis. We conducted a 42-week two-center one-arm observational study to assess the efficacy and safety of ustekinumab in treating patients with stubborn GP. The demographic and clinical features of 29 patients with GP at baseline were documented in this table. By week 16, mean PASI scores, BSA, and PGA values had decreased significantly from baseline, and this effect was maintained through 52 weeks. 7 patients with GP had a short disease duration, while 22 had a long disease duration. Notably, compared with the patient having long disease duration, those with a short disease duration achieved PASI 75, PASI 19 in higher proportions and at earlier time points throughout the treatment and follow-up period. Moreover, the patient with a shorter disease duration require fewer doses, and those with a longer history to maintain completely clear skin for 52 weeks. The percentage of patients with a CAF14 mutation versus those without who achieved the PASI 75, 19, 100 is shown in figures. Patients with a CAF14 mutation in GP respond particularly well. We performed univariable and multivariable analysis to explore the potential factors associated with treatment efficacy. Apart from CAF14 mutation, positively, no other variables showed a statistically significant association with achieving PASI 19 at week 28 in multivariable analysis. Although GP resolves spontaneously after a few weeks or months, but 40% progress to plaque type psoriasis or even PSA. Interferon gamma plays a key role in GP development by activating APC to produce inflammatory cytokines and chemokines. It is mainly produced by adaptive immune cells, including the TC1, TH1, and TC17+1 subtypes. 12 is a key regulator driving the naive T cells toward the TH1 phenotype, so we conclude that IL-12/23 inhibitors present significant efficacy and a good safety profile in refractory GP patients. The last section is efficacy and safety of JAK1 inhibitors in refractory palmar-plantar pustulosis. These years, there are great advances in the pathogenesis of PPP. PPP lesions share partially overlapping transcriptomic signatures with AD and PSO lesion. TH1-270 pathway were all significantly upregulated in PPP. Pseudo-timed trajectory analysis for the identifying TH17 derived cells with predisposition for TH2 differentiation. FC and IF assays revealed includes the GATA3 positive and CD4 positive T cells in both peripheral blood and lesional skin. IF and IH assays were used to assess the expression of Th1, Th2, and Th cells, along with their associated cytokines in lesions on palms or soles from 16 PPP patients, 10 chronic asthma patients, 10 PV patients, and 7 health controls outpatients from our department. The expression of Th2 cells, IL-4 and IL-13 in PPP were comparable to those in CE, but more abundant than in healthy control and PV. The expression of Th17 cells, IL-17 and IL-36 gamma in PPP was similar to those in PV, but higher than in healthy control and chronic asthma. The expression of Th1 cells and interferon gamma in PPP was similar to those in CE, PV, but higher than those in HC. Based on the complex immune response pattern, we chose the JAK inhibitor for the treatment of PPP just because it has multiple therapeutic targeting clinical applications. In our study, 10 PPP patients received upadacitinib were followed up to evaluate the efficacy and the safety. In PPP patients received upadacitinib, the shortest time to achieving PP-PASI 75 and PP-PASI 19 was 4 weeks and 8 weeks respectively. The proportion of patients achieving PP-PASI 19 at week 16, 24, 52 was 70%, 100 and 100 respectively, and no SAE were observed. Therefore, JAK inhibitor deliver significant efficacy and a good safety profile in refractory PPP. Finally, let's make a brief summary. In the management of specific psoriasis subtypes, IL-17 inhibitors rapidly elevate the edema pruritus and rash in P patients, and as a swift effects on the non-acropostular GPP with especially good responses in pediatric cases. For AGPP, genetic testing enables precise drug selection. In refractory gutted psoriasis, IL-12/23 inhibitors deliver significant efficacy alongside a favorable safety profile. And refractory PPP patients treated with JAK inhibitors experienced a rapid sustained improvement without SAE. Thank you so much for your attention.